Hi, and welcome back to the Ask Us Anything at CGH. Dr. Bird is out learning more stuff out somewhere, so I am filling in with him as a guest host. I am Dr. Eric Kuhns. I'm a family medicine physician here in Sterling for a little over 20 years. So we've got lots of interesting stuff, and I'm going to concentrate on a lot of commonly asked questions and pitfalls today. Fair warning, I'm a car guy. There may be some car comparisons here, so if you have any trouble with that, feel free to ask. What I'm really getting at. Hopefully, it helps illustrate some stuff. Um, so first, starting with the common pitfalls. Who is getting into trouble and why? What are we seeing that way, both nationally and locally? The first one is the people who say, "I haven't had it. I must be immune. I've been exposed long enough." If you haven't had any sort of infection or vaccination and you have no immunity, when it finally does find you, all the options are open, including some of the serious ones. And we certainly have seen that some. And these people are often the most surprised that it's, after all this time that it hit them and hit them hard. And I have a particular, what comes to mind is a middle-aged young woman who was otherwise fit, who was words where I didn't think it would be this bad. And for the most people, it isn't. And she probably could have reasonably expected that it wouldn't likely be that way. But if you look at the people who it just breaks bad in, people who have the bad outcomes, the worst cases, that's often the case. Another big one, and this is especially relevant right now, is we are starting to get a lot more early therapies available, but there's an emphasis on early. And one of the things that I often see people is, or people fall into the trap of, I feel fine, so I'm not going to go seek care, even though I'm a reasonably high risk person. You should seek care based on how high risk you are, predominantly, and not necessarily how you feel in the moment. If you have something that might be COVID, get tested and get seen, because a lot of the stuff that works really well has to be started within the first 5 days. 5 days. That's a pretty tight time frame. We've all heard about with stroke how important it is to get in right away, because a lot of the therapies that have to start, within that golden hour or things along those lines. The This applies to an extent with COVID too. If you're more than 5 days out, a lot of the early treatment options become no longer effective. Some of them are good through 7 days, and the monoclonal antibodies have some effectiveness through 10 days, though clearly there's a tailing of that effectiveness as you go on. So if you're, over 50, certainly over 65, if you're, if you're overweight, you have high blood pressure, high cholesterol, that sort of stuff, and you get COVID, it's probably good to check in with your doc. Now, that may just be a conversation about what to watch for and what the time frame is. That doesn't always entail treatment, because they're, as good as these things are, it's important to note that most people still get better whether we treat them or not. So there's a threshold. If we treat people who are too low a risk, even rare side effects become more common than the actual benefit. There's something called the number needed to treat. How many people of all comers would we have to treat to get one good outcome? It's a little different. They talk about like a Paxlovid has an 80% reduction in hospitalizations. Well, that's only looking at the people who actually get hospitalized. If you're looking at all the people who come in, most of whom aren't going to be hospitalized no matter what we do to them, we have to treat about 17 people to keep one person out of the hospital. And that's one of the best options that we have. For the options where, they decrease the rates about 30%, and like molnupiravir, now we're looking at, you got to treat 30 some people to prevent one hospitalization. So we have to be a little more circumspect about, are even more minor side effects going to add up to greater risk for all the people who would have gotten better anyway than the one person we would help in that group. All right, so I already touched on this a little bit, but another common pitfall is, who's at risk. A lot of people are like, I feel I'm pretty healthy. I'm probably a low risk person. Well, being a little overweight is a reasonably significant risk factor, and being a fair amount overweight is a very big risk factor for this. And people kind of discount that sometimes. If you have high blood pressure, high cholesterol, people think, oh, it's a respiratory thing. It's only if I have bad lung issues. Not so much with COVID. We see a lot of blood clots, a lot of other issues. So it's really important to realize that a lot of us are a little higher risk than we think. I mean, I like to think I'm a pretty healthy person, but I have high blood pressure. That puts me at a little higher risk for COVID as well. So people often underestimate their risk quite a bit. Another big common pitfall, and this is very important with Omicron because Omicron's changed the game here, is atypical symptoms. In fact, some of the stuff we relied on before, like, you've lost your taste and smell, was a real solid thing that this is almost certainly, maybe that's a strong word, but very likely was COVID. We're not seeing that as much, and it's not as reliable with Omicron that you lose your taste and smell as a big clue that this is definitely COVID. What we are seeing a lot of is sore throats and gastrointestinal digestive issues, nausea, vomiting, diarrhea. Sometimes there's no respiratory symptoms at all. Omicron really seems to like to bind to the throat and the back of the nose. So, and it seems to do that more preferentially than the lungs as much as Delta did. So it changes the symptoms. The good news is it tends to make for less severe disease of the lungs. The hospitalization rates for Omicron are about a third of what they were for Delta, which is good. The downside is because Omicron was so much more infective, we saw about 4 times the number of cases in the same time. So there still ended up being a lot of people in the hospital just by those factors kind of balancing themselves out. So be aware of gastrointestinal symptoms, be aware of sore throats. Testing is more available. You can get testing free by applying online through the government. And I think that's actually done through the post office. But in any case, I know quite a few people have gotten their tests. My family's gotten some tests as well. They do send them to you. It actually does work, which is amazing because this is the government, right? But we do see people actually getting tests. So having rapid tests around will help. So Matt just put up where to find your free mail order tests. So limitations of rapid tests. If you once have symptoms, they get significantly more reliable. If you're trying to predict, am I going to be contagious when I go to a party tomorrow? They're not nearly as good at that. If you're not having symptoms and you're trying to see if you have a really early infection that you don't know is going to cause issues yet, you really need a PCR test for that. But for am I contagious right now, the rapid tests are better. There's some thought that throat swabs might improve that a little bit, but the tests we have now haven't been well studied that way or approved. So we don't know for sure if throat swabbing is going to add to this. If you decided you wanted to pursue that, please swab your throat first and your nose second. But again, that's certainly uncertain. So Marilyn Letcher says, if I had COVID, why will you always test positive? Well, no, but you might test positive by PCR for a long time. Now, there are different types of tests. The PCR test looks at genetic material, so the genetics, the RNA of the virus itself. And just like dead people have genetic material in them still, that's how we do forensic stuff, right? Dead viruses still have genetic material in them. And as we clear that out, we still find that in the secretions and the swabs that we do, sometimes for even months after a person has had an infection. You're still clearing out viral debris and some viral RNA. So those tests can stay positive for a long time. They're not necessarily a good measure of when are you still contagious? Can I go back to work? That sort of stuff. Because they can stay positive long after you're symptomatic or particularly contagious. So The rapid tests are a little bit better that way. They is when the viral load starts to drop, they turn negative. Now they may turn negative before you're completely not contagious, but it's a fairly good bet that you're not very contagious if you've been symptomatic and had a negative test. It's not perfect, but it's probably the right test if you're really wanting to know more about that. In terms of the new guidelines with the 5 and 10 days, keep in mind that it's not like they've decided that contagion goes away at 5 days. They've decided that it's enough less that if you use a good mask carefully, that it's reasonable to go back and do things, especially when you're really needed, like in healthcare or other areas. If you're feeling well and you're 5 days out and you're clearly masking, that risk is low enough that it's reasonable to go back. But the risk isn't zero, it's just on its way down. So it's still important to do those things. And if you're not masking well, you're not being careful, you can still infect other people. So will you get vaccinated? Can you still get COVID? I'm going to get to that because a lot of that's changed, and I got a lot of specific information on that. So I'll circle back to that in a moment. It's definitely a good question. All right. So other common pitfalls: high risk people not getting a booster. Our rates of adult vaccination 65 plus is 85.5%. That's pretty decent of the people who've gotten their first 2 shots. However, the rate of boosters is only about 30% of people who've gotten vaccinated have gotten boosters. And if you're a reasonably high risk person, 50, especially 65 plus, and you haven't gotten a booster, your risk of getting sick and even hospitalized is starting to go up a fair amount. It's a significant difference. And we are starting to see more hospitalization in people who are fully vaccinated, but high risk and not boosted. So, we're seeing some people come in from nursing homes and also people who are just older in general, immune compromised people who are undergoing chemotherapy, or in some levels, even people who don't have a lot of comorbidities but are old enough, and they get sick enough that they end up in the hospital. Now, in general, if you've seen this before, either by infection or by vaccination, your immune system spins up a secondary response, and those people don't get as sick for as long, but sometimes it still crosses a threshold that they end up in the hospital. So that's another pitfall that, I'm just going to rely on what I had. I don't really want to get a booster. If you're in a high risk occupation, a high risk person, that risk is really starting to go up. And let's get into the details of that a little bit, and I'll answer this last question in there. So first, if you're vaccinated, can you get Omicron COVID? Absolutely, you can. And so people say, well, what's the point? Fair question, right? Yeah. The idea of vaccination is, at least in part, not to get sick at all. So let's look at those numbers. If you were just vaccinated and did not have a booster, we just have data out now in the age of Omicron that you only decrease your risk by about 50. Now, this is not 50-50. It doesn't mean there's a 50-50 chance you get it. It means that half of the time when you would have gotten it, you won't. So that's something. But when people are in the community and 85% of adults are vaccinated, so the vast majority of adults who might, who are your associates, are vaccinated, even if we decrease that number by 50%, a lot of vaccinated people are getting COVID. So it is still happening. The risk is certainly less. You have to keep in mind, seatbelts decrease the risk of death in a car accident by a little over 50%. So it may surprise you that most people who get killed in a car accident were wearing their seatbelt. That does not mean the seatbelt's worthless, but since the vast majority of people wear their seatbelt, a 50-some% reduction isn't enough to make the raw numbers equal. So that effect applies here too. Matt and I, who runs the behind the scenes stuff we're talking earlier, if you have 100 people vaccinated and one unvaccinated, and you have two people in the hospital, you can't have more than 50%, or there's only one person left to be in the hospital who's unvaccinated in that population of people. So when our numbers of people vaccinated starts to get pretty high, even a few breakthroughs amounts to a fair amount of people. So let's move on to what happens if you get a booster. Well, if you get a booster, now you're up to about an 82% reduction. So that is a significant, still fairly good protection. Is it the 95% that we had initially with Alpha? No, it's not. Omicron has certainly changed the game that way, but 82% is still quite good. And this is the risk of infection at all. Now, it's important to note that not all infections are the same, and this difference is quite a bit different. I'll use a car analogy here. Not all accidents are the same, right? You can have a really safe car like a Volvo, and you can get in an accident, and you have airbags and crumple zones and all that stuff, or you can get in an accident in your 73 Pinto. Okay. Those accidents are not likely to be the same. Yes, they're both accidents, but the outcomes of those are not likely to be the same. There's a significant degree more protection to be had beyond just whether you're in an accident or whether you get COVID or not. What we see is a lot of nuisance infections. You get colds, sniffles, that sort of stuff, and people who are vaccinated and some who are boosted as well. But there's proportionately less time that they're generally sick, and severity, especially when it comes to hospitalizations. So let's look at hospitalizations specifically. So if you're vaccinated alone and not boosted, versus someone who is unvaccinated, the unvaccinated person has a 5.5 times higher risk of getting of ending up in the hospital. This is out of a very large study out of California that was done in the time of Omicron. So we're now getting some Omicron data, which is good. If someone is not vaccinated and you are vaccinated and boosted, that person is now 23 times more likely to end up in the hospital. So the benefits start to multiply when we talk about more serious disease. So what tends to happen here is people look around in the community and they're going, well, I got all these friends who are vaccinated and getting sick. This seems useless to me. And I get that perception because that is happening more often. We are seeing more breakthroughs for nuisance infections, especially in people who are just vaccinated and not boosted, but some of both. And us doctors, we look at people who are in the hospital and we see the 40-year-old or even the 30s that we know shouldn't be here. If they had gotten vaccinated and particularly boosted, their young immune system would have taken COVID and strangled it. I mean, it would have seen that and been able to respond well, and we wouldn't have seen them in the hospital. But because we see all the bad outcomes, that's what we see. We see the tragedies where the 39-year-old and the 40-some-year-old, they end up ventilated or dead or have long-term complications, long COVID issues. So we see a lot of those things. So for us, it's pretty clear that, vaccination is still very, very, very useful. It decreases all the risk, but especially the outcomes that we see. So I can see how there can be a disconnect here. But I think it's important to know the outcomes that really matter. We'll get over a nuisance infection. We just don't want to end up with life-changing illness, not being able to work, having to drag around an oxygen bottle, ending up on a ventilator, ending up dead. All those things we've seen happen in people who it shouldn't have happened to. We know they would have had a good response because they had a healthy immune system to make that response. They just ended up with a very high viral load or had some other, things that they weren't thinking about enough in terms of risk, maybe a little extra weight or something that still got them in trouble. And this brings me to one other thing. There's this broken clock argument that I hear a lot about, And this comes with vaccination. Well, they told us it was 95% effective. Now you're saying that even in people who are boosted, it's in the effectiveness for infection is 80 some percent. Or if you're just vaccinated alone without a booster, it's only 50 some percent. Well, they lied to us before. So that means that we were always right. We told you that the vaccine didn't work. Now it's finally coming out that it's less effective anyway. So we were always right. Well, this reminds me of the broken clock. Someone says it's 4 o'clock, and you say no, it's 2 o'clock, and they say no, it's 4 o'clock. Well, now it's 3 o'clock. It's still not 4 o'clock. And then when it gets to 4 o'clock, they say, aha, it's 4 o'clock. Look, the clock says it's 4 o'clock. My clock says it's 4 o'clock too. So therefore, I was always right. It was always 4 o'clock. No, that doesn't. You can't go backwards like that. Those things were wrong then in the context that they were we had then, and because it's at least more right now or closer to right, it doesn't make it right all the way back then. It doesn't mean people lied to us before. So be careful how those things are pitched, because a lot of stuff is meant to inflame or scare on both sides. There's a lot of that because that's what sells in media, right? Yeah, being scary or blame. All right. I've kind of skipped over a little bit how we're doing here locally, and I know everybody likes to look at that. So Matt, if we can throw up the weekly update. So 7-day case rate, 1,500 cases per 100,000. That's coming down, but high still. We're still seeing a fair amount. The 7-day positivity percent is 16.8%. That's come down just about 3% the last week, and it is trending down, but we're still at a pretty high rate. We'll look at that in a moment. Whiteside County residents greater than 5 fully vaccinated. So everybody that's eligible, we're about 60% for everybody that's eligible. Now, remember, I said it's 85.5% for the really high risk people. So when you're comparing groups, vaccinated versus unvaccinated, the unvaccinated group includes a lot of kids who haven't gotten around to getting vaccinated yet, a lot of young, healthy people. And when we reduce the risk of those people who are 65, we're not reducing it all the way down to 0. We reduce it down to maybe the level of a young person. So if we're seeing similar outcomes than an 85-year-old that's vaccinated and a 18 or 20-year-old who's unvaccinated, that's pretty good success. It's not down to 0, but it's pretty impressive. We can bring in a person who is old, their risk all the way down to a person who's young. So, all right, let's new hospital admissions, 15. That's down 37%. That's definitely good. We are definitely seeing a significant improvement in the stress on the hospital. That is good. Unfortunately, what we're seeing with a lot of people who were really sick before, some of those people are not making it out of the hospital, and we do have 5 deaths to report, and that's an unfortunate thing that those bad outcomes tend to tail. People are often in the hospital when COVID goes bad. It really drags on. Those people are often in the hospital for a month or 6 weeks or sometimes even longer yet. So especially those people, those real tragedies we talked about, the young people who we wouldn't expect to be here, boy, they are tough, and they can suffer and fight a long time. Anyway, Matt, let's move on to some of the rates. So the 7-day moving average of daily cases, you can see there that we shot up to a really high rate versus our peak with Delta. We've been kind of bouncing around that, although it seems like we're on a downward trend now. Hopefully that's a more permanent one. Unfortunately, again, over the last few days, we've had, between 2 and 4 people pass away in Whiteside County, although that looks like it's coming down too. And let's hope. All right. That would be huge. All right. I think we're done with the graphs there, Matt. So thanks. We'll get back to a few other things. There's some new data on pregnancy and stillbirths. There was a long study of a pretty large study of people who were infected with COVID at the time of birth. What happened at that point? And stillbirths were doubled if you were infected at the time of birth. So, although that number the number of stillbirths is fairly small, everyone's a tremendous tragedy, and doubling that rate is something that's very sad. So we knew for a long time that pregnancy increased the risks of COVID to the mother, and we've seen that. We've had to do emergency C-sections on young women who were intubated from COVID. So that the risk to the mother was pretty well established. We're now also seeing that there is a stillbirth risk that doubles as well. So again, if you get vaccinated, now let's say you're on the fence, you're thinking maybe it is time to get vaccinated, and then you're looking at this. Well, 2 doses only gets me a 50% reduction. That also needs some context here. Most people who've gotten 2 doses got it a year ago, so their immunity has come down. If you're getting 2 doses now, your protection would be significantly better in the near future, probably closer to what a boosted person is, because you got those high levels that we need to try and stop Omicron right at the door. It really requires really high levels of antibodies to stop it at the door. It's much easier to stop it before it gets all the way down into your lungs. And that's what the immune memory, the secondary response, your natural T and B cells, if they know what to look for, you can spin up that secondary response. And both people who've been infected before and people who have had vaccination have that ability to spin up a response sooner. Now, if you've had both, you've had hybrid immunity, we know that's the best, and by a significant margin. I recently started a study on that. I apologize, I don't have the graph for it. Maybe we can put it up later, but it looks at hybrid immunity versus regular immunity, and there's definitely a difference there. So getting boosted and getting your booster the hard way, so to speak, through a breakthrough infection, both provide significant protection in the future. Let's talk about kids a little bit, because there's more vaccinations available in young kids, and there is talk that maybe we'll finally be able to vaccinate younger kids. Yeah, that's been a long time in coming, because the safety bar keeps going higher and higher the younger you go, because where the risk is less. Remember, we talked about that number needed to treat. How many people do we have to give something to prevent one person from having a bad outcome? The less the risk is in that population to begin with, the bigger that number gets, the more people we have to treat. If to put it in car terms, if you're on the racetrack, we only have to put seatbelts on a few people to keep them out of injury from accidents that happen there, or rubbing is racing, that sort of stuff, because it happens a lot more there. If you're talking about regular people driving out in the country, you have to have a lot more people wear their seatbelts before that seatbelt saves one person. So when we're going down to kids, that safety bar is higher, and it as it should be. So we're taking more time. We're building on what we know before, and also looking in more depth. But we are getting close to being able to do that. So looking at death rates is tough, because kids generally don't die of much of anything very often. They can suffer through all sorts of stuff. And, we've certainly seen the highest rates of hospitalization through the whole pandemic in kids happen during Omicron. And it wasn't because kids got sick more often. It's because so many kids got sick. Again, Omicron is very good about breaking through the door of your first line of defense of immunity. And we're seeing, I guess I should mention this too, we are seeing a lot more reinfections. I've talked about vaccination a lot, but we are seeing a lot more reinfections. People who had Delta in, sometimes even November, December, they get Omicron in January. That's That's something we didn't see before. Omicron is very good about getting around that first layer of defenses. Fortunately, it doesn't seem to be as much about causing deeper infections, but it's still the hospitalization rate is there. It's about a third of what it was before, but it's still significant. So in kids, one of the things that does happen a little bit more often is this multi-inflammatory system COVID. It's a generalized inflammatory state, often has myocarditis as a part of that. So we saw in kids who were unvaccinated, this is a study out of England. England has really detailed records because everybody's in the same health system, and they keep very good track of this. A lot of good science going on in Great Britain. So they looked at almost all the kids' infections in Great Britain, and they were able to see about 113 cases of this multi-inflammatory system COVID per million kids. Now, for perspective, that number went all the way down to 1.1 in vaccinated kids. Because remember, kids have a good immune system. They make fantastic responses to immunization. They really have better protection than adults yet in terms of how well their immune system is able to prepare for the next infection based on being shown it. So this is a very marked difference of something that can be life-changing. We hear a lot about myocarditis in vaccination, and it's a real thing. We need to not discount that, and it does come into play in who we decide should get what vaccination. So if you're in the highest risk group for vaccination, you're a teenage male or male around puberty, that risk starts to get high enough that you might think about which vaccine you pick out, because that risk is a little higher with Moderna, and the extra effectiveness of Moderna, which is small, it's real, but it's an incremental increased effectiveness, may not be worth the increased risk of myocarditis in that population. So if you're a young male, a teenage male where you're into the age range where you might be able to get Moderna, or maybe even in your early 20s, in that population, maybe you think about getting Pfizer instead, because it has a lower risk of that. Or this is getting a little bit deeper into things, but if you're a young person who's recently had an infection, you say, I've got pretty good immunity, I just need a boost, and I don't want to take much in the way of that sort of risk, and I'm a young male, maybe I could even consider a Johnson & Johnson for a boost. It's clearly not the most effective, but in that scenario where your risk is already down some, and you're trying to build on that pre-existing immunity, it might be reasonable. It's something you could talk through with your doctor. If you're a young female person, well, Johnson & Johnson has that rare blood clot risk that was seeing a lot more in young females. Well, that changes it. Then you have risk on both sides. You have a little bit more risk in if you're a young female of the side effect from the vaccine, and you're at risk from the lesser protection. It doesn't make much sense there. So again, this is some nuances that you can talk through with your doctor. But getting back to the myocarditis thing that I started this whole tangent on, when myocarditis, it's a scary sounding thing. It sounds like a heart attack or something along those lines. In rare cases, it can be serious, but fundamentally, it's an achy heart, so to speak. If we've all had flu or some viral infection where we've gotten all our muscles are sore, it hurts to move. Sometimes it even hurts to move your eyes around because all the muscles are sore. That's inflammation of the muscles. If this happens to the heart's another muscle, then that becomes myocarditis. It's also an inflammation. Many times, though, it's self-limited like that. Your heart is sore, it hurts, you have myocarditis, but it's self-limiting. It goes away like the other muscle aches and pains do. Now, if it gets severe enough that it causes scarring or permanent damage, that's a whole nother thing. And it can in cases. It happens a lot more often in COVID, where you have that high level of inflammation for many days. You're sick for a long time, versus when you get vaccinated, you have that immune response typically for 24, maybe 36 hours or so, and then it goes away because it's not continuing to reproduce and cause ongoing issues. So if you want to, I had this conversation with a mom this morning. If you want to stay away from myocarditis, especially the serious versions of myocarditis, you don't want to get COVID. That's where the predominant risk lies. The best way to prevent that, the best tool that we have is of course getting vaccinated. And if you pick your vaccine out well, that risk becomes pretty vanishingly low. And then, of the options in front of you, because unfortunately, COVID is everywhere still with Omicron in particular, your risk becomes less and not more with that. Okay. I got another question from Jan Wiersum. I'm a 76-year-old woman and my immune system has been compromised, and I was vaccinated last January and February and had a third full dose in September. Will I need a booster or a full dose when 6 months from September? So good question. And I appreciate you keeping up on this. Your kind of wounded immune system needs to be poked and prodded a little bit to keep up with this. So when you get to the interval for your next booster, my understanding is that, and I guess I shouldn't even really necessarily use a booster per se as a term. You really need the full level of stimulation. So my understanding is if you're immune compromised at a significant level, like organ transplant or having to take immunosuppressive medications, your immune system doesn't respond to the booster level doses. You need a full dose. That doesn't apply. Pfizer's booster and regular dose is all the same, but it does apply to Moderna. Moderna has a half dose for its booster. So hope that helps. And I'm glad you're keeping up on this. For the high risk people, it's a bit of a pain, but you really got to keep after this, but we can markedly reduce your risk if we keep on top of it. So thanks for the question. We can start to open up for other questions. How can a doctor prescribe Paxlovid if they do not know which pharmacy has it since distribution is spotty? Yeah, so let's get into a little bit about those medications. So Paxlovid is our first line now. There are 4 different options that we have in line. Paxlovid, monoclonal antibodies, IV remdesivir, which we should have available by next week, and then molnupiravir is the 4th line option. So we do have several options now. Your question is very well taken. How do we prescribe it if we don't know where it is or who has it? That is an ongoing battle. And there was a time when Omicron first hit that Paxlovid wasn't yet available locally. Molnupiravir was real spotty, if at all. We were running out of monoclonal antibodies, the only ones that work, because a lot of the monoclonal antibodies don't work against Omicron. There is one that we have access to that it does, and the IV remdesivir wasn't ready for outpatient use yet. So we were really struggling right when this really hit. Now we know that both Walgreens and Walmart have Paxlovid. We try and keep up to date with emails to the staff about where those things are at, but I often will still call a pharmacy and say, hey, I've got a patient who needs it. Do you have Paxlovid? Because that's my first choice. And if not, then we move on to our second choice, which would be the monoclonal antibodies, and we try and set them up for that. So it's kind of in these days where everything is kind of touch and go as far as availability, although it's a lot better than it was even a few weeks ago. It's kind of incumbent on your doctor to leverage the staff and call around and see what the options are, because we need to know pretty quickly. If you're at day number 4 or 5 of symptoms, that window is getting close to closing and we got to get on this. So the normal thing of, we send off something to the pharmacy and hope for the best may well not be enough here. We may have to call, but Walgreens and Walmart are the places that have Paxlovid. Lori Shipman says, can you please touch on antivirals and how they will change the course of variants and mutations? It's a very good question, and I don't know that I have a great answer for you. Will there be some pressure to get around the antivirals? There could be. The one thing that we've seen so far is the area of or the area in the process that Paxlovid and molnupiravir target they're not antibody sites that are easy to mutate. They're part of the reproductive process. Paxlovid works through an enzyme that's needed for the virus to reproduce itself, and the molnupiravir sends in faulty building blocks, so to speak. So the virus dies of its own mutations. There is a little bit of a concern that molnupiravir, because it makes these faulty building blocks, could cause genetic changes or issues. That's never been seen, and similar things have been used in HIV, but it's at least a theoretical possibility, and it's something we would need to keep an eye on. But I would say that though we don't have strong data on it now, by first principles, what we would expect is these areas are much harder for the virus to work around. They're very critical. They're not surface proteins. They're not things that the antibodies are looking for. They're critical parts of the process. So hopefully we'll have good effects. And we've seen that through Delta and Paxlovid. The monoclonals were the biggest hit. Most of our monoclonal options went away or became ineffective, which is, Regeneron, all those sort of things that worked so well in the beginning became ineffective with Omicron. There is still one. I'm not going to prescribe it or try and pronounce it because I still haven't got my handle on that one. It starts with an S. But anyway, good question that way. Marianne Jones, with the way this variant has spread, could we get some level of herd immunity? Yeah, I mean, Omicron has been incredible at picking out people who have been careful. People have made it through a lot of time without getting in trouble. It is finding most everybody without any immunity, or at least a lot of them, and also some reinfections. So the big question that we haven't answered completely is, how well does Omicron protect against Omicron? You need a certain amount of time between infections to know it's really a reinfection and not just an extension of things. So I haven't seen a lot of data on that. Now, this brings into, there's a new subvariant of Omicron. The original Omicron is BA1. I think of the A team with this, right? BA Baracus. That's how I remember this. Now there is a second BA Baracus, BA2, which is slightly more contagious yet. If it's hard to believe, but it is, I think, a small difference. And it's not clear that Omicron or BA1 is protecting real well against that. What we're seeing is it seems to add on to the tail of infections. It's not causing new spikes, but instead of having a rapid up and a rapid down, as BA2 comes in, it seems to slow that progression down. So there may be some effectiveness still, but it's not complete. So, I mean, in terms of, I guess I should divide this out. In terms of severe infection, our body's ability to spin up T and B cells to protect against severe disease, I think we will see continuing benefit that way. We've really seen that be a lot more durable, whether you've been infected before or vaccinated at any level. That severe disease, especially in people who have really, good, robust immune systems, that seems to be much more durable than nuisance infections. I'm not as optimistic that we'll be able to reach herd immunity from nuisance infections. I think we're going to have to live with that. If you really want to stay away from nuisance infections, you may need more boosters more often. For me, that's important. I don't want to be out of work at all. I don't want to risk infecting patients. So I'm going to keep taking whatever needs to be to make that happen. For other people, that may be less important. So good question. Christian Andrew Walrath, do kids under 5 unable to be vaccinated and contract COVID, are they still needing to be vaccinated when they turn 5? Excellent question. So I think the official thing is yes, you don't know how good of protection that they got. If they got a mild infection, we know they'll certainly get the best immunity, the hybrid immunity, if they get vaccinated. Adding some nuance to that, though, you're taking what's already a fairly small risk. All right, you've made it lower in terms of, if you got through the first infection, now you have some level of immunity, so that risk is lower, and you're trying to take that smaller risk and making it smaller yet. Yes, you can make it smaller, but you're taking smaller and smaller slices of the pie. So do I think that it's critical that they get vaccinated right away? No. I think that I would give them a time to get fully recovered, try and pick out a good time that they're not going to be particularly bothered by the day after side effects, a weekend or a Friday, something where they can take it easy the day after. And then I'll be interested to see some data, on that, because I think there's an open question out there about kids who respond to this really well and they already have some immunity. What about one dose? Maybe that's enough. I don't think we've seen a lot of data on that in kids, and it would be nice to see that and see how that might play out. But anyway, so it's a good question. I think the answer is yes, but not necessarily right away. And again, at least a reasonably good question about, do they necessarily need both doses right away? Officially, again, I think the formal answer is yes, but that's just based on trying to be the most safe all the time. And I don't know that we have good data to compare one dose versus two. Other than that, one dose already looks pretty good, but direct comparisons we don't have. So other questions? Samantha Weathers, I'm hearing a lot of parents in the community talk about unmasking kids in school and the population in general. There are concerns about social development, mental health issues. Is there a specific point that we need to get rid of masks? Very good question. It may come as a surprise, but there is a very reasonable amount of debate about this in young kids, even in the scientific community. There is benefit, and as you pointed out, there is harm to wearing masks, and figuring out where that lies in a given population is open to some debate for sure. The World Health Organization states that below 6, they don't think the risk is high enough to mandate masking. The CDC says 2. I don't know that either of them are wrong per se, but they have different priorities, about how they're weighing one set of risks versus another. I do think that if we can get kids, and this to me is one of the better arguments to get more younger kids vaccinated, because if we get them well vaccinated and protected with the best tool that we have, then that residual benefit from masking becomes, you're trying to take slices out of a pie that's so small that it's hard to weigh that very heavily against the risks of speech development, social interaction, that sort of stuff. Those are real things, and those are things that I think need to be weighed very significantly here. So I wish I could say that there is a specific point where that happens, but I really think we need to start thinking about that harder, especially in younger kids, and especially as more kids get vaccinated. The best meta-analysis that I've seen on mass risk reduction is about a 50% reduction with a well-fitted surgical mask. And again, there's a few caveats there. Do kids always have a well-fitted surgical mask? It's not always the case. So I don't know that we can say that, on a population basis, we get a 50% benefit in terms of risk reduction. On an individual kid, if they're good with it and they're wearing a good mask, you may see a 50% reduction. But on a population basis and how the average kid uses it, I'm not sure that we're there. So this is something I think we need to really think hard about. The best tool we have is getting kids vaccinated. And as younger kids get vaccinated, have that really robust response that they have, now we've taken their risk from this big to this big. Is it worth it to make it that big? through mass and the the issues that they cause. It's a good question, and I don't have the answer, only food for thought on for you. Next question. All right, I'm not seeing any further pop up at the moment. We'll give it one more moment. Oh, there we go. Mary Jones says, "Thank you so much for doing this. And I hope things are getting better at the hospital." They are. There's a little bit of angst about, are we really getting there? Is this going to bounce again? This, COVID in general has proven amazingly resilient and adaptive and difficult to predict on all sides. I remember way early on when there was 60,000 deaths and it was coming down. It was, geez, this is all it was. This is like flu. Well, it turns out that wasn't the end by any means. We're up well over 800, almost 900,000 now. Is this the final chapter of the severe hospitalization surges? I hope so. I think there's some reason to be optimistic that between better vaccination rates, Omicron-induced immunity to severe disease, and just less people. I mean, the people, again, the really tragic cases we see are the people who have no pre-existing immunity, it seems. And again, those are often the people who are like, we've been at this a long time. I've been exposed. I've never been sick. I don't get sick. Those are the people that we see get into real trouble. And it's a real tragedy when they end up on a ventilator. There's less and less of those people out there, just, by the numbers. And what we're seeing a little bit more, again, is high risk people who are not getting their booster. They've been vaccinated, but not getting their booster, starting to make up more of the population. And I worry about the complacency again that way, as far as future surges, that we tend to have a short memory. Next year, when we've had a nice summer, everybody's feeling good. Are high risk people going to go get a booster? I don't know. I hope so, but I think our memories become short, and we stop worrying pretty quickly about that stuff. And so there's still some angst in the staff about are we done? But I think we are feeling, the effect of less serious admissions. Our numbers are significantly less. The hospital is no longer bursting at the seams. We are seeing the tail end of some of those tragic cases that have been there for a long time and just not being able to suffer more. Marianne Jones says, have we been seeing many cases of the flu? Well, flu is back. Last year, I think we saw like one case locally, and there was one pediatric death in the entire nation from influenza. And this is not because we were not looking for it. I need to disabuse that. For the first time, we checked every last person who went into the hospital last year for influenza. We did a multi-part swab that had that. So we were looking for it because we wanted to know, are we treating one or both? Or we need to isolate influenza people? And we had the technology to do that. So last year it was almost non-existent. It is back. It is not yet bad locally. We have seen a few cases, but not a flu surge yet, although it's not unusual for that to happen in late February or March. So we're not out of the woods that way, but so far it's back, but not bad, at least yet. So let's cross our fingers and hope for the best that way. All right. Well, again, as I always like to sign out, please let's recognize that this has been a really stressful time for everybody. Give people the benefit of the doubt. I think most everybody is trying to do the best as they see it. Sometimes I think there's a lot of misinformation that drives some of how we see things, but let's give everybody the charity of assumption that they're trying to do their best, and turn down the volume on some of the testiness. Realize that we're all stressed, and that stress makes us pop off a little easier, and we need to make an extra effort to be good to each other. And I got a personal note from the family member of one of the people who had unfortunately not made it with COVID, And she said, my family's not always the easiest to deal with. I really appreciate the way that this nurse explained things and took care of things. This is not my patient. They just reached out to me because I do these sort of things. That was a really nice thing to hear. I passed that on to the nurse and the nurse supervisor. Those are the sort of things that we can do more of. And I think we ought to make an effort to just be appreciative first and try and spend some time understanding, because as big a thing with this pandemic as the rest of this is it's frayed the ropes of just about everybody at some level. And we need to actively rebuild that. So let's spend some time and effort just trying to give the extra thank you, the extra bit of patience, the extra bit of time and understanding. So with that, we'll sign out, and I'll be back the next time Dr. Bird is out doing something, learning something or doing something critical that he needs the day off. So thanks for having me. Take care. Goodbye.